Hello, hi, good evening, doctor. Can you hear me? Is my voice audible? Dr. Shine, can you hear me?
Yes, doctor, I can hear it.
Okay, perfect. Thank you. Okay, so it's already 9, so I'll start with the template and see how it is going. The session will be recorded so that people who are not able to join probably would be able to listen to it later. So, as we had discussed in the last class, we had a few information giving scenario on how to do an information giving to a patient, how to talk about information giving about a treatment to the patient, how to approach a teenager. Those were the topics, and educational scenarios were the topics that we covered in the last class. Uh, this class, we will try and do an approach on how to do a breaking bad news station, how to take a consent, how to manage critical incidents where a medical error has happened, and how to approach a difficult conversation scenario. So these would be topic for today. Just to recap, this would be the template that we can use for all the topics, and there will be a little tweak here and there for each specific topic, but the overall template would remain the same. So as our template goes, like you go inside, you introduce yourself with your name and your designation or the role. You say you're a registrar in the pediatrics or whatsoever, and then you prepare the uh, p- you prepare for the interview where you make sure you're talking to the right person. You confirm the patient, ensure there are no interruptions. Also ask them if they want anybody else to attend with them, and then you go directly introduce the task. Only few exceptions where you don't go and directly tell the news, like a breaking bad news scenario where you give a kind of hint before you break the bad news. In all other scenarios, make sure you introduce the task right away in the start so that you don't waste time beating around the bush. So you introduce the task, quickly recap. So by recap we mean you should understand how much they know about the situation already. So that is called understanding their background, and always invite them to interrupt. And then you do the main bit, which is delivering of the information. If there is too much of information that needs to be given, it should be broken down into small chunks. After you deliver one part of a chunk, ensure that they are understanding what you're talking through. So that is called chunk and check technique. For certain scenarios, illustration would be ideal for you to explain the scenario. So make sure you illustrate where it is appropriate. And finally, you should be able to wrap up by summarizing what you've spoken so far and what would be your immediate next steps. Always ensure that you involve your seniors, your team. If there are leaflets available for chronic conditions, you can provide them with leaflets or signpost them to appropriate groups. For example, if it is a cancer or Down syndrome or something like that, you can signpost them towards a support group. If the patient wants to complain, you can even signpost them to Pulse. So that is the overall overview about a template. Now coming on to the specifics of today. First, we will discuss on how to approach a breaking bad news scenario. So in breaking bad news, the template is the same as I said, but what you can do here, you don't want to be disturbed in the middle of your conversation, because this is breaking bad news is one station where the emotions are too high. You need to address the emotions first, name the emotion, address the emotion, and then move on. And also, you want to make sure it's all sensitive and your voice is very empathetic. And also, make sure there is no disturbance. So, in this scenario, in the initial part, you can say that you will not be disturbed by a bleep, or you have handed over the bleep to somebody else so that nobody disturbs us. And also, in the initial part, ensure that ask them if they want anybody else to be present while you're going to talk about this information, and then set the scene. You can say that you're here to talk about so and so's report. check their understanding and expectations. So establish the background. As I always say, you can ask how much are you aware about Charlie's condition. So they will be saying something, and that clinical information would be useful for you to build up further communication. And then you can say, yes, I'm here to talk about his reports. And then before giving the bad news, for example, if his reports suggest leukemia, don't go and say, yes, his reports suggest leukemia. No, that might sometimes sound rude. So give it a pause. Say you, I wish I had better news, or you can use n number of many other sentences to give a shot to say that there is something unexpected news that is going to follow. So you give it a hint to say the news is not so good. So you use that as an empathetic sentence and then talk about the new information. Don't do too much of empathy. Use only one sentence to understand the background, one sentence to kind of hint them that the coming news might not be a very good news. After you tell what the information is, don't talk in detail. If this is a new diagnosis which is going to be heartbreaking, like a brain stem death and all those things, don't go into too much detail of the condition, because whenever you receive a bad news, your mind is not in a state to absorb too much of educational stuff. It can only absorb few things which is relevant. So when you give a new information, quickly go through what it is and talk to them more about the implications of information, what it would mean to the patient, to the family, and how we are going to support, what would be the next steps. So your aim should be to deliver those things in a way that you can support them rather than giving too much of medical information that is not tested here. Here, more of your knowledge is not expected. What is expected you out of you is that you should be quite empathetic. You should be able to manage the scenario with if the patient is crying, if the patient is angry, because there are different phases of uh, grieving. So whatever the phases, you should be able to address them. So emotion plays a huge part, more than your information. And then give them some time. After you give a breaking bad news, if they are really upset, give them some time, allow them to take their kerchief, give them time for the news to suck in, and answer the concerns honestly. You don't have to rush. And after that, you can in the end, you can summarize. Always in these type of scenarios, make sure you offer another meeting. Say that you're there, available anytime they want more information on. Also, if they have more questions, ask them to write down so that they can ask further questions, and give reassure them that the entire team is there to support them through this difficult time. Okay, and then if there is available in certain situation, you can direct them to support groups or leaflets to give them more information about the thing that you have spoken. If the patient is crying, give it a pause. Don't continue with your information. Offer them a tissue. Ask them if they need some water, and give some time. The pause might sometimes feel very uncomfortable. Even a very few second pause in an exam will feel uncomfortable. But that is essential for you to get over your conversation smoothly. Give that time. Okay. And then use empathetic response. That is very, very important in a scenario with breaking bad news. Any doubts so far? So anybody joined at all? Okay.
No, doctor.
Is that clear? Okay. Do you like to do a scenario?
Okay, I will try.
You can try. Yeah, okay. Have you, when are you planning to give, doctor, your exams?
Maybe after 6 months.
Okay, okay. So you're an early part. Okay, so just look into the scenario and see whatever. This is a common scenario that we see in newborns. Do as much as you can. Okay, I'll give you 3 minutes to look into the scenario, and then we will do the stuff. Okay.
Hello, doctor. Hello.
Yeah, can you hear me? Are you ready? Hello? Can you hear me, doctor? Hello? Can you hear me? Can anybody hear me?
Yes, hello, ma'am. Yes, ma'am. Hello.
Okay, perfect. Yeah, Dr. Shane, can you hear me?
Yeah, I can hear you. Actually, it's not my earphone is not that good. Hello.
Okay. Yeah, can you hear me?
Yeah, I can hear you.
Okay, okay. Do you want to try?
Yeah, I would like to try.
Yes. So
Uh,
you can
uh,
you can
okay.
you you can start, doctor.
Okay. Hello. Hello, Mrs. Blackburn. I am Dr. Shine, one of the pediatric registrar working in this hospital.
Hi,
Am
doctor.
I speaking to Charles' mother?
Yes, doctor.
Okay. Okay. First of all, Mrs. May I call you as Mrs. Blackburn?
Yeah, you can call me Dr. Mrs. Blackman.
Okay. Actually, first of all, congratulations on your newborn baby.
Thank you, doctor.
How are you feeling now?
Uh, yeah, a bit overwhelming with whatever is happening with Charlie, but yeah, I'm getting there, doctor.
Okay, I can understand your situation. Actually, do you know why I have called you for this meeting?
Not sure, doctor. Is there anything with Charlie? Is he all right?
Yeah, that's what the meeting is about Charlie. Before we start, I would like to know that I have switched off my bleep and I have handed over to my colleague. And also, do you want anybody to attend the meeting with you?
No, doctor. Only I am there.
Okay. Okay. Before we start, can you tell me how much you know about Charlie?
Um, Not much because there are too many things going ahead with him. They did say they had done few things, put him on ventilator and all those stuff. And they said for now he's been all right and stable, and that is the information I've got until now, doctor.
Okay. Okay, Miss Magburn. Along with that, I would like to tell one more news to you, and I wish that I would had a better news for you.
Is
Is that
Charlie all
we have done?
right?
Is he is all right now? He's stable in ventilator now. But
Okay.
when we have done the scan of is scan of the head. You know what is ultrasound scan?
Nobody said they were going to scan his head.
Yeah, scan means it's a kind of imaging. The imaging of the head.
Okay.
When we have done the imaging of the head, we found out that he has a minor bleeding. He's having a mild to moderate bleeding on his inside his head.
Oh God, that sounds dramatic. Is he going to die?
Not like that, Mrs. Blackburn. It is not. Such things will not happen like that. It is not about that. It is that the newborn, your baby, he was born very premature, almost 3 months before the due date,
Okay.
and because of that, the blood vessels flow inside our body, the blood tubes through which the blood flow.
Yeah.
And that is very fragile. That is very fragile inside the head actually.
Okay.
So when the baby is born very prematurely, with the all care we give, there is high chance that the baby may the blood vessels of the head may break and it may bleed.
So is Charlie going to be all right, or is it something serious, doctor? Because bleeding
Uh,
in the brain, I've seen few elder people in my family having bleeding in the brain and then completely bedridden. Is Charlie going to be the same?
the that bleeding is totally different from this bleeding of the newborn. As of now, the bleeding has been classified as grade 2.
Okay, what does
Grade
that mean to me?
The grade 2 bleeding means see, we have I am drawing the ventricle, and I'm drawing the ventricle and showing to the mother that there is a space inside the blood called ventricle, and it is bleeding into the ventricle. And hello.
Yeah, yeah, yeah. Continue. Hello, I can hear you. Hello, can you hear me, doctor? Hello.
Okay. Sorry,
Yeah.
sorry. The net connection has gone. Actually, I'm
Okay.
a little
Good.
bit traveling. Uh,
Okay, no worries.
and actually, because of the bleeding into the ventricle, this particular as problem has occurred, and we call it, because it has bleeded into that ventricle only. We are calling it intraventricular hemorrhage, and since it is only a moderate type of bleeding, that means, as I shown you in the picture, there is a space inside our head called ventricle,
6 minutes
and
up. You have 3 more minutes.
the ventricle is being covered by the brain's matter. So there is no bleeding into the matter actually. So I can assure you that the bleeding is only moderate.
Okay. So is
And
Charlie going to
we
be
have
all right?
seen that. Hello.
Yeah, is Charlie going to be all right, doctor?
Yeah, he will be, as of now, as a team of the doctors, we have seen him, and he will be fine. Like, means we have seen children with grade 2 bleeding has successfully overcome it, and we have seen that they are going to be fine. Only the minor problem he will may face is that there will be he can have some kind of weakness in his limbs, like that, but that also, with the proper therapy we can overcome it. But I assure you, as of now, there is only mild to moderate bleeding. In mild to moderate bleeding, we have seen that people will children will recover, babies will recover actually.
Okay, so
Did
he
you
he might not be a special child, is what you're trying to say.
Most probably, he won't be a special child. That's what I want to say. But we have to be very careful on the coming days. That we have to be careful that bleeding will not increase, and also for that, as the team of doctors, we are managing as a team. We will be very careful. We will be giving the treatment for the baby,
So,
everything. But
what needs to be done to Charlie right now, doctor? Is there anything that you will do for his bleed?
for grade 2, actually, we don't do much. There's no treatment like that for that. Our only precaution is that bleeding we won't increase. As I told you before, there are different grades, like grade 1, grade 2, grade 3. We hope and we take precautions that the grade won't increase, like it will become grade 3, grade 4. Grade 3, grade 4 means that, as I told you before, now bleeding is inside the ventricle, but it may extend into the part surrounding the brain. So we are taking precautions that it won't extend like that.
Okay, doctor.
Hope
Is
you
there anything that
understand me.
I need to do or anything that has caused this because of me?
No, no, it is not because of you. Don't think like that. And you, as a doc, I have informed you. It is your duty to be informed every bit of your child. That's why I have
9 minutes,
informed
sir.
you. Uh,
Do you want to continue?
so, okay, I'll continue.
Yeah.
That's what we would like to tell you. That we I can also give you leaflets regarding the care of the preterm and care of the brain hemorrhage, what we call in this child, in our child, intraventricular hemorrhage. And I will also arrange an if you want another meeting with the consultant. Are you
Okay, doctor.
following me, Mrs. Blackburn?
Yeah, yeah, doctor.
Okay, so can I summarize what I have already told you?
Yeah, doctor.
Okay, today I came to speak about Charlie, 5 day old, who was born preterm with a birth weight of 670 gram. On the scan done at day 5 of life, it has come to known that he is having grade 2 intraventricular hemorrhage. So, uh, we have informed the mother regarding the importance of the imaging and also its implications in the future. And I have also informed you regarding the treatment, the precautions we are going to take it, and
Okay,
also
doctor.
on follow up on the coming days.
Okay, doctor.
It's okay. Okay. Thank you, Mrs. Blackburn, for your valuable time.
Thank you, doctor. Okay. Okay, well done. Thank you, Dr. Shine, for being brave enough to try this scenario. For first time, I would not want to find any fault. Trying to attempt in itself is a huge thing, and you made sure that you tried to follow the template as much as possible, handing over the bleep introduction and everything. So I think you had a template that was followed. That is the first step that needs to be done, and you're okay with this template. But what we expect is for you to always become better. So some of the points that I'm going to highlight is for you to improve further, because you still have 6 months
Okay.
time. You will keep on improving, okay, and you will not repeat
Yes.
this.
Yes.
Once you start trying, it becomes more and more
Easy.
polished as you
Uh,
keep trying, okay. One thing
uh,
I always stress upon is read the question carefully, write down the names of the child and the mother. You're not
uh,
supposed to change their name. So this
oh,
is Charlie. However, initially you mentioned it as Charles.
oh,
Okay,
okay.
and
Okay. Uh,
also Blackburn turned to something else at one point, and then again you came back to the correct name, because this is the
okay.
first
Okay.
time I did not take it specifically that ways, but for exams, never ever dare to change their names. If you don't remember the
Okay.
name, look into the paper and then talk to them. You're always given a paper and pen. There is also the candidate information leaflet inside. If you forget, you can have a look at it and then talk. The ideal thing would be for you to note down. You are sitting there outside for 3 minutes. Make sure you note down the important points, and also, if needed, illustrate, draw it when even before you enter the station. Okay, so that is one thing that you have done. Don't do that name. And then illustration. Have the illustration ready at the station so that you can explain. You say explain easily. However, you remembered and started illustrating after you spoke about it a bit. And the other important thing in breaking bad news, as I said, like, you followed the template, but the most important thing is to address the emotion. The only thing you used is I can understand, but there are many other sentences that you can say. Like, for example, I can see that this has been very stressful for you the initial few days, now that you've given birth and lots of things are going around with Charlie. So use sentences like these, okay. It is very stressful. We are with you. So always acknowledge their emotions and reassure that you are with them. That gives a good kind of communication, okay. And then try to avoid as many medical jargons
Okay,
as
doctor.
possible.
Okay.
Okay, okay. I can see that you're traveling, so it's okay. As far as you're able to listen to me talking, it's perfectly fine. So use few empathetic sentences, and also don't use too many medical jargon. So you kept on saying ventricle, ventricle, and all those things. Once you can explain what is ventricle, like how you when you illustrate, you can say there are water fluids fill spaces inside. The brain surrounds it and all those things. This fluid fills space is called ventricles, and then you can just talk about there is bleed in the brain. Okay, make it simpler. Don't use many jargons. Okay, always use illustration. That is very important. When the mother said that she is not aware of the scan being done, then because it's the first time, I'm not getting angry or anything, but the role player can be in any state of mind, can do any tricks to you. So be careful. If the mother says that nobody told that he's going to have a scan, then you can say that this is a routine scan that we do on all the babies born premature, kind of a screening to ensure that they are okay. There are no further complications. So you can try to pacify like that. Okay. And then you should be able to use more and more empathetic sentences. For example, as soon as you say bleed in the brain, she is going to she is going to be shocked, and she is going to be very much worried for the baby because the baby is born preterm. So you always name the emotion. I can see that the word in itself is very frightening, having bleed in the brain. However, let me reassure you that this is not an uncommon condition in babies born as early as Charlie. And most of the time, if the bleed stays the same, they do very well. So you reassure and then say what it means to Charlie, what you're going to do. So what will you be doing? You'll be doing repeating the head ultrasounds over the coming days and weeks to ensure that this is not going to spread anymore. As for now, you're going to monitor how the baby breathes, the vital signs like the heart and all those things, and make sure he is all completely stable and he is in very close monitoring. That is what you can do. Okay, so these are few things that you can talk about, and you should understand that the treatment here is symptomatic. Grade 1, grade 2, grade 3 is not going to make any sense to them. You can say that there are different grades, but as of now, we can think that at this stage, it is more like a mild to moderate bleeding, and then stop there. One thing that is reassuring, the fact that there are no changes in the brain tissue is a positive sign. And then you should let them know that this ultrasound only shows you the structure, not the function of the brain. However, these kids will be followed up very closely to ensure how their future is going to be. Okay. So I think we will stop there for this scenario. Any questions so far from people who have been listening?
Yes, ma'am. Ma'am, thank you.
Yeah. Yeah.
I have one question regarding
Yes.
in the last slide you have mentioned that there is no problems in the structure. What I say, ma'am?
Pardon me?
I don't understand your things. I have some confusion regarding this slide. You told that there is no problems in the structure or in the tissue.
No, no, in the brain tissue, because this in grade 1 and 2, you have the intraventricular hemorrhage. It is not
Yes.
intraparenchyma, is not involved.
Yes.
So once you draw, you can say that this bleed is within the fluid spaces. It has still not reach the brain tissue, which is classified
Okay.
as a higher grade, and the effects are more severe. As of now, it's mild, but you'll have to say that you're going to closely monitor to see how the bleeding goes. The only other thing is this ultrasound will be able to look into the structures of the brain. It will not be able to tell the function, in the sense how some of the parents will be worried, like, is my child going to be handicapped? Is he not going to work? Is he going to have weakness? That you can say that this is too early to predict anything like that, because these images can only show any structural changes, but the function of the brain we would be able to assess as the baby grows. Do you understand what
Okay,
I'm
ma'am.
trying to? Yeah, yeah. Okay, fine.
Yes. Yes, ma'am.
Okay,
Yes. Thank you, ma'am.
no
Okay.
worries. Any other questions before we move on to the next topic? Today at 10 o'clock, we will be, so I will try to finish the template for the remaining three types of station. Uh, the practice of one or two station will be happening after 10 o'clock. If the people here wants to do the scenario, I'm more than happy to give you the chance. If not, I will offer it to the general floor over there. Okay. Uh, okay. So I assume there are no further questions. Any further questions? So that is about how you approach a breaking bad news. Be more empathetic uh, and address the emotion first before you proceed to giving any amount of information. Without addressing the emotion, any amount of information will not get into their brain. So ensure you address the emotion. Next, coming to the consent stations. How to take a consent. Are you able to see the screen?
Yes, ma'am.
Okay. So coming to consent stations, when you're going to get a consent from the patient, from the parent, you will have to give detailed information about what you're going to do to the child. What will that mean? Why are you doing it? And is there any risk that the child will? You will have to address all these things before you take consent. You cannot just explain the procedure and say why you're doing it and take a consent. You should also let them know if there are any side effects that might be expected out of this procedure. So coming to the template would again remain the same. Introduction, the naming and all those things. And then you definitely understand try to ask the parent how much they understand about the child's current health. Then they might be saying that the child actually had fever, headache, not himself. And you can pick from there and say, yes, exactly. So anything like this, we would think it might be a brain infection. So to confirm that, we might need to do a procedure called lumbar puncture. So for consent scenario, don't take too much time in explaining the disease condition. If you take at least some people keep on talking about the disease condition up until 4-5 minutes that they don't have any time to talk about the procedure and take consent later on. So handle these situations carefully. It might look very easy, like taking a consent for lumbar puncture might feel very easy, but if you end up talking about meningitis more than lumbar puncture, then that will end up being a disaster. So you briefly understand what is the child's current status like, acknowledge the concern, and then say that you are here to take consent. So always say why you are here. You want to do lumbar puncture and you are here to take consent for the procedure, and you will be talking about the procedure. So that is what your aim should be, and also you should clarify this. Once you clarify this, and it will go smoothly. So then you explain the need for the procedure and indication. As I said, you should always talk about the indication. Why is this child needing this procedure? After you tell that, you should tell how it is done, how, like the position of the child, what they should be doing, does this require fasting, anesthesia, and all those things, and also anticipated outcome. For example, here if you're doing a lumbar puncture, you would expect to find some organism that will uh, help you to choose an appropriate antibiotic. It will help you to discuss about how long the antibiotic needs to be given and all those things. And also any risk associated with it. For example, if it's a lumbar puncture, they can have headache, they can have infection introduced into it, the procedure in itself can fail, and all these risks can occur. They can have a leak syndrome and all those things. So all these are the side effects that might appear due to your procedure. But because this is a common procedure, none of it might also happen. The way you say these side effects and risk in itself is essential. You can't just go and say like lumbar puncture, there are few side effects like the child can have headache, he can have infection, the brain infection can be introduced through the skin. We might fail the procedure. No, you don't do that. Don't list down the risk factors. What you can say is there is a possibility of any procedure when it is done, there is a possibility there could be infection. However, we will ensure that the procedure is done in a sterile technique so that the possibility of infection is low. So that is how you tell about the side effects. You tell what are the side effects and what you can do to minimize this risk. Only then they will have this uh, they will be confident to consent for the procedure. If you just list all the side effects, anybody will get scared and will not give consent. Okay, do you understand this? So whenever you say one side effect, also tell what you will be doing simultaneous. For example, some children might have pain. For that, he might have an headache following a procedure because the fluid is drained. How to decrease this? So we would advise the child to lie on the back for at least 1 to 2 hours, hydrate themselves adequately. If the pain is too much, we'll also be able to offer some painkillers. So that is how you talk. Do you get it? You don't randomly say all the side effects and move away. You should say the side effect and also simultaneously say what would be done to minimize that. That is the right way. And that kind of gives the parents some confidence that things will be taken care by the doctor, even if it goes otherwise. And also, in certain situations, if there are any alternatives, you can talk about the alternatives. Once you have spoken about all these things, then you finally summarize and also let them know what decision has been taken. Most of the time, they might say, okay, you're happy to give the consent, or some of the parents might say, I have to discuss with the other parent. Look into the situation, how it goes, and say what decision has been taken. And you should, at all points, make sure the parents are understanding what you're talking about. Okay. Any doubts so far on how to do a consent station?
No, ma'am.
Okay, perfect. So these are some of the consent stations that had appeared in exams. So please prepare. So when I put this, it means it is your responsibility to read about these. You can use the NHS leaflet or anything else. Don't go very deep, but try to cover these topics, these subheadings of each procedure. So read about this more and more medical when you're in the earlier part of your preparation. If you have 6 months down the lane to give your exams, prepare all this, make quick notes for you to revise. That would be the easiest way and quickest way for preparing. Initially, you'll have lots of time to prepare. As you go towards your exam, it should be more like practicing, practicing, practicing. Any topic you give, you should be ready. So these are some of the consent stations that we have seen in our clinical exams. Next, coming on to the other topic, I'll finish the two more topics and then we'll come back to practicing these stations. So next would be on how to deal with critical incidents. So critical incident, by which I mean there has been an incident. For example, a medical error has happened. You might have given a wrong drug, wrong dosage, wrong patient, anything would have happened. So all these are critical incidents where there has been a compromise in the patient's care. And you should talk in a way that you're really apologetic. You should not just ignore it and say that it is not of much importance, nothing will happen. No, you don't do that. You sincerely apologize. You acknowledge that there has been mistake on your part, but don't blame anybody. You say that there has been a mistake and you look into it and proceed further. Here you should never blame any colleague or anything. That is very important in critical instance. So how do you approach these stations? As I said, the template is the same. You should be able to apologize sincerely. It doesn't mean throughout the scenario for the next 9 minutes you should be saying, I'm sorry, I'm sorry, I'm sorry. No. So there are many different ways of apologizing. Use different words. I'm sorry. I sincerely apologize. This shouldn't have happened in the first place. You can use many different types of sentences, ready-made sentences. English might be difficult for many people, so use some ready-made sentences. Have at least 4 5 sentences for each emotion that you can use when there is a need. Okay, so apologize sincerely, but don't apologize overly. I'm sorry for every sentence. No, you apologize sincerely and then say what has happened, what will you be doing. So what are all the stuffs in the delivery of information you should be covering? So first you should say what went wrong. For example, you can say that a wrong drug was given, so mention that clearly. And likely risk, what will happen because of it, so that you should explain. Also, if the child has already come to some harm, You can say that, or if there is something that you are expecting, for example, if the child has received an overdose of gentamicin, you might expect there might be some hearing problem in a few kids, and that you are going to screen this child for hearing before you discharge. So those are the kind of harm that you can explain to the mother or the parent to say what harm has already been done. And also you should discuss about what are the steps you have taken so far to keep the patient. For example, if a wrong drug has been prescribed, you should say that we have already stopped the drug and we are monitoring. So you should also mention what are the steps you have already taken to keep the patient safe, what has been done so far, and what will be done to ensure that this will not happen again. So this should not happen again for the same child or for any other child. So one way of doing it in UK is something called as incident reporting. In a local in each setup, the incident reporting pattern might be different. They might use a different type of software or different type of thing. The basic thing is incident reporting, so that is what you should remember. So you're going to report this incident. In some of the places it is called as datix, that is the medium through which they do this incident reporting. So don't get flabbergasted when somebody says datix. It is nothing but incident reporting. So you can keep yourself simple and say that you're going to report this incident. Okay. And also, if definitely some of the role player will be very, very angry. They would not compromise. Even after you explain, sometimes they feel like they want to complain. Don't hold them. Don't say that, please don't complain. No, we will sort of, no. That is not your job. Your job is to fulfill your duty of candor, saying what has happened, what will be done, how will you take care of this child, and all those things. If the parent is still not satisfied, wants to make a formal complaint, you should also be liberal to direct them towards that process, direct them to the hospital complaint process. And that is something called as PALS, and critical serious incident monitoring procedure, that is done in the hospital. So just you can tell that I would be able to direct you towards the complaint process if that is what you want to do. Okay. Sometimes there has been a medical error, might have happened, but the child wouldn't have come to any harm at all. It would mean nothing to the child, but it would come under critical incident. In those situations, sometimes the parent will be like, my child has not come to any harm. This is not going to change anything to my child. Why are you even bothered to tell me that? In those cases, you can use something called as duty of candor. So you can say that as a doctor, you have certain duties, and one of them is duty of candor. That is basically volunteering an information to a person who has come to harm while you're caring for them. So that is your duty. Whether the patient has come to harm, not come to harm, it meant something or it did not mean anything at all to the patient, you're still, it is your duty to be open, honest, and truthful. And that is the reason why you're talking about this incident to the parent. So that is how you deal with critical incidents. Okay. Any doubts so far? So these are some of the medical error situations that we have seen, like giving a patient who's already allergic to penicillin. Somebody has written a penicillin injection to that child. Gentamicin overdose, very commonly seen also. Practically, we see that quite often in newborn unit. Asthma, giving a double dose aminophylline, change in the name, giving a different drug. Wrong breast milk is also something we have always seen. There has been a scenario where people have done lumbar puncture because the blood culture report has been wrong to a child who didn't need a lumbar puncture. So these could be many different variations in medical error. All these comes under medical error, and you follow the same pattern and go along with addressing their concerns. Any doubts so far on how to go with medical errors? The template is the same, but you should ensure that you discuss these things: what went wrong, what risk the child might have, what are the steps taken, and how. Definitely do not miss to talk about incident reporting. This is very specific for this scenario, critical incident. So incident reporting, basically you investigate further to see why this error has happened in the first place, and you try to derive at many other ways on how you can avoid this from happening in future. That is basically incident reporting. Any doubts so far, guys? I assume no then. I hope you're all able to listen to me
Yes,
still.
ma'am.
Okay, okay, okay. Sometimes I need that reassurance. Okay. So next we will talk about difficult conversation, how to, so the difficult conversation, usually any colleague situations, like if you want to say a colleague has had an alcohol and come to workplace, not doing a discharge summary, is not getting along with the team, all these again falls into difficult conversation because you don't know how to talk to a colleague, because it is quite difficult to point out to somebody's mistake. Those all might come under difficult conversation. And sometimes the patient, any patient for that matter, any topic you have listened so far might become a difficult scenario if the person, the role player is difficult. So So coming to those, so a difficult conversation can be with the patient or with the colleague. For example, a child, an adolescent who is very resistant to be transferred to an adult clinic. Anorexia nervosa teenager, which is very commonly appearing in exam, who refuses for admission, or there are lots of other teenagers. Teenagers are usually difficult. MMR, sometimes the patients might be very difficult where they don't want the treatment that we insist would be better for the child. Or sometimes they would be requesting for some scans or anything where we feel that is not at all needed. Whatever the scenario might be, your job is to give them the correct medical information, try to convince, if not give them enough information, and see if you can. If you're not able to manage, always make sure there is an escalation plan. Say that you can arrange a meeting with your consultant and all those things. Always have an escalation plan with you. There are no beds, the surgery has been delayed diagnosis in DDH. All these are difficult because the parents are definitely very angry and anxious in these scenarios. And the other thing is colleague issues that we have seen frequently, sometimes like a colleague who comes under the influence of alcohol, who doesn't do his work like a discharge summary or other things. Somebody who has altered the notes, social media usage, putting the patient's information in social media. All these are some of the difficult conversation that we see. So when you talk to a colleague, as I said, again, the template is the same. However, when you talk to a colleague is somebody you know, you're working with them, somebody junior, somebody senior, or somebody working along with you. So always never be judgmental. We are nobody to judge somebody else's work. What you are here for is to ensure that you're giving up the patient the safe environment. If that comes to compromise because of a colleague doing something, you should address that in a gentle way and know how you escalate it to your seniors or anything. So when you talk to a colleague, you just don't go dash with him and say this is all these are wrong. No, you always go ask them about their general well-being, like how are you doing, how are you finding the posting. If the it is a junior new colleague, then you can say this is a new department, how are you getting along, is there any difficulties with the work or anything. So you start with the general well-being. Do you want, should we talk this over a cup of coffee and all those things, because that is the way it happens in UK. So because you're giving an UK exam, you might be expected to have that kind of rapport with the colleague or the patient. So always start with asking the general well-being and then introduce the task. Say openly, don't beat around the bush. Say that I'm here to talk about something uh, which has been a concern. Give them a hint and then say that the nurses are worried that they can smell alcohol on you. So introduce the task and then say, are you aware of it? So the colleague might say something. See if they agree or if they disagree. If they have a argument for it, is it real or unreal? So you're not in a place to judge whether it is real or unreal. Just see if they are aware of the problem. Do they agree with the mistake? Never be judgmental, because some things might be accidental and you might have received a false information and all those things. So don't be judgmental. Say that you are here because you are concerned or somebody is concerned about the colleague, and you openly address the issue. And then say, if the issue is there, then you talk about what are the advantages and disadvantages. For example, if this is a colleague who's come under the influence of alcohol, uh, you should uh, you should make them understand that that is not something expected out of doctors. And alcohol has its own side effect. Like their judgment might be compromised. They might say something that they shouldn't be saying. Their inhibition is compromised. There are lots of problems when a person is under the influence of alcohol, and it is not safe to be around the patients when somebody is under the influence of alcohol. So you should always say, address the issue and say what it might or what are the problems it might lead to. And your work doesn't stop there. So just by pointing out there has been a problem and just telling that this is all wrong, you should not be doing it, doesn't, the problem doesn't end there. You should also give some ideas to resolve in a non-judgmental way. See, it should sound more like a support. For example, I can see it might be stressful. Is there anything that I can help from my side? Is there anything that you want to talk to me? You can ask them to see if they can open up, and then say that, for example, in alcohol colleague, it is when a person or doctor is under the influence of alcohol, he cannot be around the patient. It is a very uh, when it comes to patient safety, it is something, it is completely unacceptable. So you can't let them, if he says, okay, hereafter I will not do it, it doesn't resolve the issue. I should find out what is the root cause. If they need more help, for example, you can direct them towards their medical supervisor or the occupational health team, or see if they need a psychiatrist help or anything. Give them ideas to see if they can go for help somewhere, get the help, and also say that, give them suggestions like, probably you can take off, talk to your supervisor, see if you can take time off from your work until you recover and resolve this issue, because you don't want to be compromising the safety of the patient. And once it is done, it might also result in the GMC taking severe action if something like that is found. So you can uh, tell all these things and convince him so that he goes, he gets help and he recovers. After you finish, you summarize like any other scenario. So always in colleague issue, ask about the general well-being. Don't be judgmental. Talk about what the issue is and how, if you have some ideas to resolve, or if you can see that you can actually direct him somewhere like an occupational health team or anything which should be helpful for him. For example, they will be able to assess him if he is fit to work here, work in this place. How can they provide him further help if he's in a depression, if he has some problems? How can that be tackled? So always direct them to a place where they can get the help from. So that will complete the scenario. And finally, you summarize, make sure that the colleague is also safe, and then you finish off the station. Any questions so far with the colleague issue? So we will, in the next 1 hour from 10 to 11, I will give a colleague scenario to practice. So if you want to try, one of you want to try, I'm more than happy to give you the chance. We will see how it goes, but please listen to how this is done. So that would be like more like a practice, real time practice session where you'll understand how the scenario goes. Any doubts so far?
No, ma'am.
Okay.
Okay.
Okay, so that brings us to the end of difficult scenarios. I have certain practice stations that needs to be done. So what I'll do now is we all can quit from this link, and we can join through the link I had posted in the general group. Do you want me to post it into your group, or you all are aware of that link? Okay, I'll post it to the group. Please join through that link. I will quit. Uh, this Zoom session. Is that all right? Any questions so far? We still have 4 minutes left if we have to discuss something. Okay, perfect.
No.
Okay. Okay. So see you in a couple of minutes in another link. Thank you, guys.